right, you're listening to Respiratory Care Modalities, a recorded lecture. By the end of this lecture, you should be able to describe nursing management of patients who receive oxygen therapy, spirometry use, flutter valve therapy, nebulizer treatments, chest physiotherapy, as well as breathing retraining, and that's the diaphragmatic breathing or pursed lip breathing. You should be able to discuss patient education and transitions in care for patients receiving oxygen therapy at home, explain the principles of chest drainage and the nursing responsibilities related to the care of a patient with a chest drainage system, and identify nursing care of patients with endotracheal tubes or tracheostomies. Okay, so oxygen therapy, the need for oxygen therapy will be determined by getting ABGs, checking their oxygen saturation, and clinical evaluations. It is considered a medication, does require a physician's order. Room air, so just you and I breathing in, you get 21% oxygen. So if they require anything higher than 21% oxygen, they will need oxygen therapy. There is a difference between hypoxia and hypoxemia, but those are indications of the need for oxygen therapy as well. So with hypoxemia, you have a decrease in the arterial oxygen tension in the blood, and hypoxia is a decrease in oxygen supply to the tissues and cells. You have low flow and high flow oxygen. Low flow oxygen gives variable performance, which means that it isn't completely accurate, and it depends on how the patient is actually breathing in and how long the tube is, how the delivery system is. There are just so many different variables that can affect the exact amount of oxygen they're getting. Low flow oxygen is generally given and prescribed in liters per minute, and then you adjust the flow meter based on what the orders are. Low flow includes a nasal cannula, which can deliver up to 6 liters per minute. Generally, you don't want to go over 4 though, because you can severely dry out the mucous membranes in the nasal cavity. A simple mask can be used to deliver 5 to 8 liters per minute. Partial rebreather can deliver 8 to 11 liters per minute. And then the non-rebreather, you would put at 10 to 15 liters per minute. And that would give them the most oxygen using the low flow apparatus. High flow is generally fixed and more reliable. So you have your Venturi mask, which is your most reliable non-invasive way to provide oxygen, and it will provide 24 to 40% oxygen. This is where you start getting orders in percentages of oxygen, not liters per minute. The trach collar can be 30 to 100% oxygen, and the face tent can be 30 to 100% oxygen as well. Keep in mind, anytime you're using a mask or if you're using the face tent, when they need to eat or drink, they have to remove that. Also, when they're trying to talk through it, it can be more difficult for them to communicate. So you need to take those into account as a nurse. As far as education goes for oxygen therapy, a patient can be sent home with oxygen, and if they want portable forms of oxygen, it can be sent home in liquid or gas form, and then they can also have a concentrator that they're sent home with. Humidity is provided for the concentrator. Humidity is not generally provided for the portable. So that's a big difference, and they shouldn't use the portable at home. They really should use the concentrator at home and save the portable for when they go out. They need to keep their follow-up appointments so that they know that they're getting the right amount of oxygen, not getting too much, not getting too little. The oxygen does need a prescription, so physicians will usually not refill the prescription, and then the insurance won't pay it if they don't get their follow-up appointments. Generally, the patient will get routine ABGs. A pulmonologist is usually the one that follows someone if they're at home getting oxygen therapy. So they'll do ABGs 6 to 12 months while they're on oxygen, and then if they try to wean them off oxygen, they'll get it without oxygen as well, just to make sure that they're still able to maintain a good level of oxygen. Okay. You need to teach them how to adjust the flow rate, just in case they have orders to increase flow rate with activity, decrease it with rest. If they call the doctor and he wants to change the flow rate, you need to make sure that the patient and family members know how to do that. They also need to know how to change out the portable oxygen and change the regulators over if one of the tanks is empty and they have to switch to another tank. They'll, once all that stuff's sent home and dropped off, the company that drops it off will show them how to do it, but if you're going in there in the home or before they're sent home, you want to make sure they really understand it. They need to be able to troubleshoot equipment. They need to know who to call if the equipment is malfunctioning, and they have to know where to get the phone number. They also need to know that they cannot smoke while they have oxygen on, and they can't just take the oxygen delivery apparatus off, put it in their lap, and smoke. They need to be keeping the oxygen 15 feet away from any kind of heat source, any kind of open flame. So that includes if they have a space heater, if they have ducts that come up through the floor instead of the ceiling, and their heat is on, that's a heat source. If they turn their stove on, that's a heat source, especially if they have gas, because then they have an open flame. They need to be aware that oxygen is flammable, and so they have to be away 15 feet away from any kind of heat source, and then 5 feet away from any kind of equipment. So a TV, a computer, you want to be at least 5 feet away. Oxygen toxicity is a thing, and it does occur if you have a patient that receives too much oxygen. So your patient receives too high a concentration of oxygen for an extended period of time. An extended period of time can be 24 hours. Symptoms of oxygen toxicity include dyspnea, substernal pain, restlessness, fatigue, and if you don't remove the oxygen, they'll have progressive respiratory difficulty. So always monitor your patients whenever they have oxygen. And then prevention is the best key. So you're monitoring them before oxygen therapy. You start with the least amount of oxygen possible, usually low flow or variable source, working your way up. And the physician does order it because it is a prescription. So you're actually going to work and collaborate with them. Incentive spirometry. This is a method of deep breathing that provides visual feedback to the patient. So your patient is going to put their mouthpiece in their mouth. And make sure it's nice and securely in the mouth. They are going to inhale slow and deep, which is going to make this go up. And then they're going to hold their breath for 3 seconds, making sure that this stays within the lines. And then they're going to slowly release the breath. They should be in a semi-Fowler's position whenever they're using the incentive spirometer. They should use diaphragmatic breathing as much as they can. And they need to perform this 10 times an hour, every hour while they're awake. If they like to watch TV, then usually say, hey, when you have a new show that comes on, during the first commercial, grab it and use the incentive spirometer. It will make them cough. So let them know it's going to make them cough, and they need to cough. But if they just had surgery and they need to splint because it's in their abdominal area, thoracic area, chest area, they need to have that splinting device available and ready. But it will make them cough. That's not a bad thing. It's a good thing. It's expanding the lungs. You're doing exercises for the lungs. Again, slow and steady. They need to breathe in slow and steady, hold, and then breathe out slow and steady. So we're not seeing who can get the highest number by taking in a very sharp breath in and then just letting it just kind of, you want to do slow in, slow out. So it's controlled breathing. You're stretching those lungs, filling them, stretching out the alveoli, increasing the ability for the lungs to ventilate and perfuse and diffuse, and then you're relaxing. They can't have nebulizer therapy. They can have it in the hospital. They generally connect the neb machine to, or the neb equipment to the wall. They can have neb machines at home, and they have mini nebulizer therapy, which is just more convenient. They need to breathe through the mouth if they're going to be getting a nebulizer treatment. That way they get the medication that they need. You can encourage coughing. If it makes them cough, that's great, because they're going to be taking in deep breaths if they're coughing and expanding their lungs, and that medication can get deeper and deeper and down. Okay. Since you are medicating them, whenever they get a nebulizer, they put medication in and aerosolize it. They need to know about what medication they're taking, why they're taking it, any side effects. They need to know how to set it up. They need to know how to break the machine down, how to clean it, how to maintain it, how to store it, when it needs to be used, not used, that sort of thing. Check for expiration dates, because people don't generally use nebulizers all the time at home, and so their medication can expire. Chest physiotherapy, you can do postural drainage, chest percussion, vibration. You can also do breathing retraining. Postural drainage uses gravity to assist in removal of bronchial secretions, and so you place the patient in various positions based on the lung segment that you want to have drained. So you're going to assess, before you do any kind of therapy or treatment to the lungs, assess respiratory status before the intervention and after the intervention. You want to drain the lower lobes before you drain the upper lobes. Chest physiotherapy is usually done 4 times a day. Generally, you're going to do it before meals because of all the different positioning. You don't want to cause nausea or vomiting, so you do it before meals and then before they go to bed. If they have respiratory medications that they take, they should take that before their chest physiotherapy, not after. You need to have suction available just in case they're not able to cough up the sputum themselves. If they can cough it up themselves, you need to have some place that they can cough it into. Look at the secretions, note the amount, the color, the viscosity, the character. Is there an odor? Note the patient tolerance. You're going to monitor your patient's respiratory rate, heart rate, and oxygen saturation level throughout the treatment. You can also monitor the skin color. Chest percussion is usually done with vibration, so you'll do percussion, vibration, like you alternate. The percussion part is done with cupped hands, and you lightly hit the chest wall in a rhythmic fashion over the lung segment that needs to be drained. You alternate that with vibration. Vibration is done for 3 to 5 minutes in each section of the lobe. And then again, monitor your patient, continuously monitor their tolerance. Be careful, look at any kind of history of degenerative disease where you might have their sternum or their rib cage more fragile, because if you're beating on it, then you can cause rib fractures if their bones are real brittle. Breathing retraining, you can teach them diaphragmatic breathing. And they can do this during postural drainage, during chest percussion and vibration, that to kind of calm them down. And then you can also teach them pursed lip breathing. So diaphragmatic breathing, they're focusing on their inhalation and pausing after they deep breathe in, and then they exhale, and they're moving their diaphragm. So you usually have them put their hands on their diaphragm, and they're wanting to push their diaphragm out and then let it relax in, and then push it out, let it relax in. Pursed lip breathing, they are exhaling longer than they are inhaling. And we usually tell them, in through the nose, smell the roses, out through the mouth, they're going to purse their lips like they're blowing out candles. So in for 2 to 3 seconds, out for 4 to 5 seconds. And they'll repeat that. And what you're doing is trying to push out more CO2 so that you can make room for the oxygen to come in. And it will slow down their respiratory rate. ET tubes. With an ET tube, you're passing the endotracheal tube through the nose or the mouth, all the way down into the trachea. And this one has right here, this thing right here is a little balloon, and it's inflated to keep the ET tube in place. Okay. It provides a patient with a patent airway, gives access to the lungs for mechanical ventilation, and can facilitate the removal of secretions by using suction. Nursing implications, what you will do is make sure that you have chest symmetry, rise and fall of the chest is equal. You will listen to the lungs and make sure that they're moving air through all the lobes. A chest x-ray is going to be done to verify placement. Make sure that your patient is on high humidity, because anything that goes through this tube here, as far as oxygen or air, is going straight down all the way through into their lungs, and you don't want to dry out their lungs and bronchioles. Okay. The tube is secured and taped in place on the patient's face. You need to make sure it's always secured, and then make sure there's clear markings for positional maintenance. So just like you put an NG tube down and you mark it so you know where it's supposed to be, the ET tube's the same way. You have to do sterile suction because it is a direct line into their lungs. You don't want to introduce anything into their lungs and further complicate things by giving them an infection. So it has to be sterile. The patient needs to be repositioned at least every 2 hours. They also have to have oral hygiene, and generally that's done every 4 hours, especially in the ICU, to make sure that you don't get any bacterial buildup, because the bacteria can travel right along the outside of that tube and then they can get pneumonia. Tracheostomy, this is more permanent. ET tube's temporary. Tracheostomy is more permanent. Now, you can have a patient decannulated, but if they have a tracheostomy, either they can't get the ET tube because of something going on in the mouth pharynx area, so they have to go straight into the trachea, or it's something that they're going to need, even if it's for just a couple of years. You don't want to have an ET tube that long. It is a surgical procedure, but it can be done at the bedside in the ICU. An opening is made into the trachea, and then they put a tube into the trachea, and that's called the tracheostomy tube. So this is what you see on your patient up in the top right corner. That's what it looks like. And then this is how you control how much the balloon inside is inflated. If they do not have a cuffed trach, then they won't have this. And then the trach ties, this actually looks kind of loose because right here there's a lot of dead space. You want to be able to fit 1 to 2 fingers under the trach, so it needs to be snug. If it's loose and they cough, then they can dislodge and displace the trach tube, which means that you have to put it back in. Okay, so this one is cuffed. They do have uncuffed ones, but you basically can instill air here. You take the syringe here and attach it. You place your stethoscope here so that you can listen. And when you listen, when it's deflated, you should hear air that escapes up the sides of the tube. As you inflate the balloon, you'll start to hear the space get smaller and smaller, and it'll get occluded. So you listen for the high pitch. Once the high pitch stops, you know that your balloon is actually hitting the tracheal wall. You'll back off again, and then that's how you know it's properly inflated. Okay. As far as nursing management, the suctioning is sterile. Trach care is also sterile because it's a direct air line into their lungs. You want to inspect the dressing and the stoma and the peristomal skin at least once a shift to make sure that there's no skin breakdown, there's no redness, irritation, or signs of an infection. You also want to make sure that the trach should be midline. A patient's trachea should be right in the middle of their neck. So your trach should be midline. It should not be off to the left or right or shifted. You also need to make sure they have symmetrical rise and fall of the chest, that they have good airflow, and check their lung sounds. Make sure you hear lung sounds in both lungs. Check their pulse ox. And when you do suctioning, you're going to have continuous pulse ox to make sure they're tolerating the procedure. They also get humidified oxygen via a trach collar. You can give them, if they have a new trach, obviously that's going to be uncomfortable, so you can give them analgesics or whatever it is the physician ordered. If they're alert and oriented, they need a means to communicate, and you also want to provide psychological emotional support. If they're on mechanical ventilation, then you want to make sure that they have a patent airway. Ensure for optimal gas exchange, so look at their positioning. You also want to make sure that if they are sedated in a medically induced coma, that they still have mobility of their extremities, so you'll do passive range of motion on all of their joints. If they are alert and awake on mechanical ventilation, then make sure that they are able to move. So don't get them all caught up in all of their tubes and wires and drains. They will not be able to speak if they're on mechanical ventilation, so make sure they have another form of communication. And then help them with coping strategies, coping measures, because they will have issues with the fact that they don't look the same that they did before, so disfigurement. Most likely they're weaker, they're going to want to sleep longer, they're not going to be as mobile as they were before, they're going to have decreased endurance. All of that they need to have help processing through. Okay. They can have non-invasive ventilation, and that's through a mask. Generally it's CPAP or BiPAP that this is done. And the CPAP provides positive pressure throughout the respiratory cycle, so inspiration, expiration, and then just the time in between where they're not doing any breathing at all. They're constantly getting some positive pressure into their lungs. It works great for sleep apnea. Your patient must be able to breathe on their own. And so if they cannot breathe on their own, you don't want CPAP. BiPAP, on the other hand, delivers 2 levels of pressure support. It's initiated by the patient taking their own breath, or it can be initiated by the machine. So the machine can actually be programmed for a patient to have, say, 10 breaths per minute. So if they haven't had a breath in 6 seconds, because that's 10 breaths per minute, then it will initiate a breath and force the pressure in. You can have problems with people who are on invasive or non-invasive vents. If the patient is on a mechanical ventilator and their alarms are going off saying high pressure, it'll say high peak airway pressure, or it'll be a high pressure alarm depending on what type of machine you have. Check to make sure there's no occlusion. Check to make sure that the patient wasn't coughing or talking or trying to work against the machine during inspiration. See if the tubing's kinked anywhere. If there is an occlusion, you can try suctioning them. Maybe they just have a mucus plug that's limiting the pressure, but the machine is telling you that they're having a hard time providing the amount of positive airway pressure that is ordered and programmed in, and so it's causing pushback on the machine. So that is, for some reason, they're having partial or a full occlusion from the machine to the patient. So check all the lines and look at your patient, obviously, see if there's any kind of distress. It can also alarm low, and that means that there's a leak somewhere within the system, so you just have to find the leak. Positive pressure just provided by the machine can decrease venous return, and that can cause cardiac compromise. If the pressure is too high, so it's been programmed set too high, then they can have barotrauma, and that the alveoli will actually rupture because the pressure is too high. As far as nursing implications, you want to make sure that your patient has an effective airway, open airway, so they have to be able to clear the airway. You're going to assess the lung sounds every 2 to 4 hours if they're having acute episodes of respiratory distress. You can suction them, you can provide CPT, promote position changes, and have them get up and walk around, and that'll increase their breathing and increase their need to cough. You want to give humidification of the airway if that's ordered, and make sure that if they have humidified air that the distilled water is always full and they don't run out. Administer medications as prescribed. If you do an intervention, make sure you do pre and post respiratory assessment to see if the intervention helped. Always tell your patient why you're doing what you're doing. So what's the purpose of it? What side effects might they have? How might they feel before or after, so that they're not as anxious, and that will help quite a bit. Okay. If they're having respiratory problems because of trauma, we're going to talk about blunt force trauma and other types of trauma in a couple chapters. But you have to also watch for infection control measures, just because foreign body has been introduced into the respiratory system. You want to make sure you do proper tube care, make sure the site's clean, the tube's clean, do good oral care. Again, that's usually done every 4 to 6 hours. Keep the head a bit elevated, because if they lay flat, then it puts more strain on the respiratory system. Provide education, emotional comfort, range of motion. If they are immobile, make sure they have plenty of ways to communicate. Again, coping, stress reduction, and then address the caregivers and family as well as the patient whenever you're talking about support systems. Okay. You can have thoracic surgery, and you would be mostly involved in pre-procedure planning, and if they're already admitted on the floor, you would go through the pre-procedure checklist, and then you also, once you receive them again, would do post-procedure. So make sure that they still maintain airway clearance. If they're supposed to be on oxygen, give them oxygen, educate the patient. You're not going to educate the patient on the procedure itself, because the physician does that. Remember that with informed consent. But you can answer questions that they might have on information they already received. You're also going to educate them on what to expect after. And you can talk to the family about how long they're going to be out, and just do whatever you can to relieve their anxiety. When they come back from thoracic surgery, obviously you're going to monitor their respiratory status. You're also going to monitor cardiac status and make sure that they're perfusing. Make sure that they have good gas exchange, so they should have proper ventilation. Their lungs should be expanding. They should be doing coughing and deep breathing exercises. That will help remove secretions. It will also help to expand the alveoli. You're going to keep their head of bed elevated 30 to 45 degrees, which will help them breathe easier. Teach them exercises while they're in bed so that they don't get any kind of thrombus, and get them up and out of bed as soon as possible. Provide oxygen to them, suctioning if they need it. But only do oxygen and suctioning if you've tried non-invasive measures, and those haven't worked. So sometimes the patient will come back from surgery. They might have a slight fever. They might have slightly lower oxygen saturation levels, but it's because their alveoli are starting to collapse and they have atelectasis. You need to make those alveoli open again so that they can have the oxygen carbon dioxide transfer. The first thing you would want to do is coughing and deep breathing, incentive spirometry. Because if you do that and you open up their alveoli, they're going to be able to have improved gas exchange. Their oxygen sats are going to go up. So you really need to look at the cause. Chest tube drainage systems. There are two types of drainage systems. There's dry and wet. Dry systems use a one-way valve, and they have a suction control dial. Sometimes it's in place of the water, or they might just have a multi-system where you can use wet or dry. but you would pay close attention to the dial. Wet suction systems do use water, and the amount of water in the suction chamber will determine the amount of suction that is supplied. So if you have a water system, you'll see bubbling in the chamber. If you see constant bubbling that isn't related to their breathing in and out, then there's an air leak, and that needs to be addressed. If they have an air leak, then they have a chance of the lung collapsing again. So chest tubes are usually put in the pleural space, and it can be because there is in the lung itself, there was some kind of trauma, pneumothorax opening that makes the lung collapse, but the pressure between the pleural space has, for whatever reason, been impaired. And so you put in a chest tube drainage system, the chest tube goes in the pleural space, and it helps to keep the area pressurized so that the lung can expand again. If you see bubbling, if they have a pneumothorax, they'll have intermittent bubbling, and you'll notice that the bubbling will occur based on inspiration and expiration, but it won't be necessarily all the time. If the tube is obstructed, then you will have no fluid going out because it is a drainage system. And the fluid will stop fluctuating if you have a water seal chamber. So those are things that you need to watch for that could be complications. Your patient will also start to get more short of breath. They might complain of more of a sharp pain or an inability to take a deep breath. But the bubbling and looking at the water, making sure it fluctuates is very, very important.